Hello, my name is Dr. Jürgen Konschak. I'm the director of the Human Sensorimotor Control Laboratory here at the University of Minnesota. And today I will speak about our project on vibro-tactile stimulation as a treatment for spasmodic dysphonia. For spasmodic dysphonia, we know it's a dystonia, focal dystonia of the larynx. And here I show you two examples of muscular activity during connected speech in a healthy person and a person with laryngeal dystonia. And just look at, for instance, the activity of this muscle here in a person that is healthy, that vocalizes or has connected speech at this point, and you see the excessive activity in that patient with laryngeal dystonia. And so what we know is that the motor system, this means is the motor cortical system in the brain is too excited, it's too excitable in spasmodic dysphonia, and that people with spasmodic dysphonia have a difficulty, or the cortex has a difficulty inhibiting that spread of activity. We know from other forms of focal dystonia, in this case I'll show you an example of cervical dystonia, that there is such a thing as an effective sensory trick. So what is it? And I'll give you here an example. So this person has abnormal head postures, as you can see here. And now he's touching his chin or his head, and what is going to happen is it restores the normal head posture, at least for a while. And so what we understand that there is a link between sensory input and, in this case, a motor output, the posture of his head. So if you're thinking about this, then you need to think about that there is a motor system in the nervous system, and that's the brain and the brain stem, in this case for voice, and there is a somatosensory system, and that somatosensory system informs the motor system. And what we have in SD, we have a voice impairment. And so the idea would be, can we stimulate the somatosensory system? Will that then regulate and normalize the activity of the cortical motor system, which then hopefully restores speech motor function? Then you may want to think, why should this even work? And it should work because there are a set of mechanoreceptors in our skin and in our laryngeal musculature. So there are touch receptors, a set of them, and there are so-called muscle spindles in the laryngeal musculature that sense the stretch and the speed of the contractions. So these type of receptors should be somewhat stimulated by these vibration of the skin. And what we've tried to do is then we developed basically a method on how to stimulate these mechanoreceptors. So we played around with a lot of different type of vibrators, and you see these encapsulated vibrators here attached to the skin of a person, and they vibrate, and they're similar to the things that you see in your smartphone when it vibrates. And if you do it at the right type of frequency, you will stimulate, for instance, these spindle responses. And how is the circuitry? What kind of a network do you actually activate? And if you, again, think about, we apply some form of vibro-tactile stimulation, that activity will travel eventually up to somatosensory cortex. And as you can see here, that somatosensory cortex is very closely to motor cortex. And motor cortex, of course, is again connected to the laryngeal musculature. So you close that circuit from somatosensory, from feeling, to actually activating these muscles during vocalization or speech. We've tried to look at this in a set of people with SD. We've tested here about 13 people, and we looked at two markers of voice quality. People came to our lab and they did a pre-test. Then we applied VTS, vibro-tactile stimulation, to the larynx, the same as we just saw before, for about 17 minutes, and that's post-set 1. Then they got a second set, so for about 34 minutes, and then they were at post-set 2. Then we waited 20 minutes, and we measured again, and that's what we call retention. And what you see here is you see that the change in CPPS, this is a marker of voice quality, and you would like to see something that is somewhere in the range between 2 to 3 or above dB. People would see that this is a meaningful change in voice quality. And you see several people really very quickly after 17 minutes got there. Others not so much, but they kind of are on the up. And then if you look at the second graph, that looks at the number of voice breaks, another marker of voice quality, you will see that these people drastically reduced their number of voice breaks, and many after 17 minutes had no voice breaks, and that continued for up to 54 minutes. So we have some initial evidence, and I'll give you now an example of a person before and after, some speech examples here.
Tom wants to be at the Army. We eat eels every day. He was angry about it all year.
So this was before, and this was after 34 minutes of vibration.
Tom wants to be at the Army. We eat eels every day. He was hungry about it all year.
So I think, as you can hear, there was an improvement in his speech. So we have some initial evidence that vibro-tactile stimulation improves markers of voice quality in spasmodic dysphonia. We also have a group of patients where it didn't work so well. Here you see there is not really a change in CPPS, but if you look closely, this group also had no voice breaks. So these were really a group of patients who had milder forms of SD, and we don't know, maybe they would need a longer dosage of VTS, and that's really one of the things that we're trying out in our systematic clinical trial.
Hello, my name is Arash Mahlan and I'm the lead engineer of the project. Here I want to talk about the current status of the project. The clinical trial involves an 11 weeks of intervention. It will start with first week that the patient comes to the lab. We have in-lab training. Also, we have voice evaluation. We record the voice. We also record the brain signal during the lab session. Then the patient takes a set of vibrators home with a power source. For in-home training, the patient only needs to attach the vibrators to the neck muscles with the tapes that we give them. Then they have 4 weeks of in-home training. They come back to the lab on week 6. Again, we have some sort of evaluation and voice recording and brain signal recording. Again, patient goes back home for another 4 weeks for in-home training, and on week 11, patient comes back to the lab and we will have the final evaluation and the recording. So having the clinical trials and its limitations, the next step is to think about how we can deliver this treatment effectively to the patients. The next step for us was to design a wearable device to make the device more accessible and portable for the patients. During the past 2 years, I was involved in designing a collar-like device that can deliver the vibrators from this to a collar like this. As you can see, we have embedded the vibrators into the collar. This system is battery operated, so there is no need for a power source or external wires. The system also has wireless connection to a smartphone app. You can control different operational modes of the system using your phone app. Another aspect of spasmodic dysphonia is that it is a speech disorder. That gives us the idea to incorporate the speech detection technology into the device, meaning that we turn on the vibrators only during speech. This will help to optimize the treatment and have more effective treatment only when the voice is symptomatic. I need to mention that this is a team effort from different disciplines. We have Dr. Godding, otolaryngologist, and also we have Dr. Watson, a speech expert that are helping us to move this project forward. Also, we have Dr. Ilan Govan and Holzwolf as postdoctoral associates of the lab. To have more information about us, you can go to our website, hsc.umn.edu, or if you have any questions about our clinical trial or the treatment on SC, you can email Dr. Ilan Govan or me for more information. Thank you.